Now, let's begin our meeting. First speaker we have is our keynote speaker from California Department of Managed Healthcare. Mary Watanabe leads the California Department of Managed Healthcare, overseeing health plans serving nearly 30 million Californians. She joined DMHC in 2015, stakeholder relations, and previously served as the deputy director at Covered California, implementing the Navigator Grant Program and Outreach and Education Grant Program. She holds a bachelor's degree in psychology from CSU Sacramento. So without further ado, Director Watanabe, the floor is yours.
Good morning. Thank you, Bobby. Mary Watanabe, Director of the Department of Managed Healthcare. Pronouns are she, her. I will say I have brown hair. If you can really see up close, there's some gray in there. I am going to share my screen and see if, let's see here. Hopefully you can see. Someone let me know if you can see my screen.
Yes, we can see it.
Yes, okay, thank you. Thank you. I love feedback. I'll try to monitor what I can, but just know I'll take questions at the end too. So let me get started here. I will just, let's see here. There we go. The mission of the Department of Managed Healthcare is to protect consumer healthcare rights and ensure a stable healthcare delivery system. I will just maybe note, I'm going to talk a little bit about our department, talk about our help center that actually can be a resource for all of you likely and your friends and family if you have challenges using your healthcare coverage. I'm going to talk a little bit about RTO and our kind of disability employment approach, our culture at the DMHC, and I'm going to have hopefully some time at the end to talk about our amazing Disability Advisory Committee as well. Just a little bit more context for my background. I think I've been in state service now for about 24 years. Stumbled into healthcare, as many of us do in state service, just happened to get a job in a department that worked on healthcare programs. Spent about half of my career really working on healthcare programs for those that were uninsured and sponsored through the state, including those with pre-existing conditions that couldn't purchase coverage prior to the Affordable Care Act. As well as pregnant women and children for anybody that remembers our Healthy Families program, whose family income was too high to qualify for Medi-Cal. I had the pleasure of working at Covered California during the first two open enrollments and the historic expansion of healthcare coverage across the state and the country. And then I've been at DMHC for about 10 years now, about almost 5 of those as the director. And have been very, very fortunate to really be able to not just make sure that we expand the number of people that have healthcare coverage, but that they're able to actually use that healthcare coverage and get the care that they need. I think there's been a lot of focus in the last few years on health disparities, particularly among communities of color. And I think that's very relevant to this group because we also see health disparities with those with disabilities. So that's a little bit about me. Now on to our department. This is our infographic from our 2023 annual report. We actually will be updating this soon, and some of these numbers will be changing. But as Bobby noted, we have almost 30 million Californians that have healthcare coverage through a health plan that we regulate. We regulate 140 health plans. That includes 98 full service plans. Those are what we refer to as full service. Our plans like Kaiser, HealthNet, Aetna, Blue Cross, Blue Shield. And then we have 42 specialized plans. These are dental and vision plans, behavioral health plans. So it's a big responsibility, not one I take lightly. But 96% of state regulated commercial and public health plan enrollment is regulated by the DMHC. When we talk about commercial coverage, I know we've got some terms that are probably foreign to folks here. We're really talking about those that get their healthcare coverage through their employer, like state employees, as well as those that get coverage where they're buying it on their own, either directly through a health plan, but most of those are through Covered California. And then when we talk about government coverage, we're primarily talking about Medi-Cal and some Medicare. So that's a little bit of just kind of some statistics about us. We regulate all HMOs. So HMOs is really what we refer to in our title of our department, managed care, where you basically are getting your care that's managed through your primary care provider. And then some PPO and EPO products as well. Um, some large group coverage, most of the small group coverage and individual products are under our jurisdiction. So large group refers to employers of have more than 100 employees, and then small group is less than that. And then individuals, I mentioned, that's primarily covered California. We regulate most of the Medi-Cal managed care plans, so the plans in each county that participate in Medi-Cal, again, dental, vision, behavioral health. We do license Medicare Advantage plans, but we only review their financial solvency. I'm going to talk in a little bit about our help center. And so if we have a consumer that comes to our help center and has a complaint about accessing care, for example, that is not under us. We would send them to the federal government Center for Medicare and Medicaid Services. Just to give you some sense of our enrollment, we're up to, I think, about 16 million in government and about close to 14 million in commercial coverage. That is, we've seen that kind of go up a little more on the government side over the last 5 years as we've seen the huge expansion of Medi-Cal, exciting there. And then just our specialized enrollment, that is primarily commercial coverage. And again, this is like Delta Dental and VSP. Just to give you some background, in California, we actually have 2 state regulators. We're unique in this. In many states, there is a Department of Insurance or something similar that regulates all of the healthcare coverage in the state. It's actually 25 years ago this year. Consumer advocate groups sponsored legislation to establish the Department of Managed Healthcare under the governor. So we're part of the administration. I'm a governor's appointee. We're part of the California Health and Human Services and executive branch. The Department of Insurance, as many of you probably know, the commissioner is elected by voters. They're a separate constitutional entity. They also regulate many other forms of health insurance. You've probably seen a lot of attention on home insurance, life insurance, auto insurance lately. That's under the Department of Insurance. They have about 1 million healthcare consumers, and we have, again, about close to 30 million. So in terms of healthcare coverage, the majority is regulated by the DMHC. I get a lot of questions when I do presentations of how do I know which regulator to call if I have a problem? And we always just say, start with the DMHC. We have 3/4 of the state is under our jurisdiction. And if it's not under us, we'll get you to the right regulator. But I thought I'd give you some context on the regulatory structure in the state. I won't get into a lot of what does that mean to regulate, how do we do that, but this slide kind of shows you some of the steps we take. It really starts with if a health plan wants to operate in the state of California, they need a license to do that. So it starts with licensing plans and approving the products that they're going to offer. We look to make sure they have an adequate number of doctors and hospitals and what we call providers in their network to make sure that they can provide all the services that enrollees are entitled to in the state. We also look to make sure that they are telling us that they're going to cover all of these services. We have very strong consumer protections in California law. There's also federal requirements that they have to follow. And we monitor their financial solvency. We want to make sure that the plan can pay for the care that they are agreeing to provide for the monthly premium that's paid. We also look at their plan, their policies and procedures. There's a lot of documents and papers that we review. It can get very technical. We also go out and do audits or examinations to make sure what they told us on paper is actually being implemented and real people are getting the care they need. And then again, we have our help center, which resolves grievances and appeals and helps with consumer complaints. And I'm going to talk more about that at the end. I'm often asked, well, what do you do if a plan is not following the law? Do you have any teeth? What's your hammer? And that was really our enforcement authority. We've had some pretty public enforcement actions that we've taken when we find that plans are not providing the care consistent with the law. Probably the big one is an enforcement action against Kaiser that we took 2 years ago related to they're providing behavioral health services, which includes both mental health and substance use disorder treatment. We also had a very large, I think 50 million combined enforcement action with the Department of Healthcare Services against LA Care, our largest Medi-Cal plan. So we do take it very seriously when plans are not following the law. So I love to talk about our help center. I think it is often the best kept secret in the state. I often hear even from my own employees that they don't realize this is a resource available to them. So as state employees, most of the products offered through CalPERS, other than the CalPERS administered plans, are likely under the DMHC's jurisdiction. And so we have a consumer help center that's available to help anybody that's having a problem getting the care that they need, or they just have questions about their healthcare coverage. I think we've assisted close to 3 million consumers since we set up our help center. But really, if there's an issue or a problem, we suggest you go to your health plan first and file a grievance. Unless it's an emergency or an urgent issue, then you can come directly to us. But we are kind of the escalation process in our second level of appeal if you're not happy with the plan's decision. I like to show this slide about what do people come to us for. In my 10 years of the department, I am always surprised that less than 12% of enrollees come to us for access to care issues. And I think if we all think about our experience with healthcare or those of our friends and family, a lot of the issues we hear about is I can't get an appointment for 2 months. My doctor or my health plan denied this treatment. The plan denied a treatment that my doctor says that I need. And so I like to highlight this because I think it's a missed opportunity. There is a process to complain. It's okay to complain if you're not getting the care you need. And if you're not getting the resolution that you want from your health plan, you can come to the DMHC. As you can see, the bulk of the issues we have complaints about is claims or financial issues, where usually with someone's premium or they're being billed for a service. Or they think they were charged too much when they received care, and then benefits and coverage is another big one. So these are complaints that we receive. The other bucket of kind of issues that come to our department are what we call independent medical reviews. So if a health plan denies a treatment is not medically necessary or experimental investigational, your doctor says you need this treatment, your health plan says it's denied, you have the right to come to the Department of Managed Healthcare for an independent medical review. We send these to an independent clinician, someone with expertise in your condition or the service, and they give an independent opinion about whether the plan should cover this service. 72% of people that come to us for an IMR end up getting the service that they're requesting or that their provider, their doctor says they need. That is a very big number. I think if most people understood that filling out a 2-page form would give you almost a 75%.
It's easy to get lost.
Apologies, Mary. I accidentally muted you. If you can unmute, I was trying to mute somebody else that I was hearing the microphone.
Got it. Okay. Can you hear me now?
Yeah, perfect. Thank you.
Okay, great. Yeah, so again, I think if most people understood that our form to apply for an IMR is literally 2 pages, you can have someone assist you as an authorized assistant. It gives you a very good chance of getting that service. So I like to talk about this every chance I get, but particularly with state employees who maybe don't know that this is an option for you. So again, share with your friends and family, but if you're having any issues with your healthcare coverage, I would encourage you to come to us. Again, if you happen to be in a plan that is not under our jurisdiction, we'll get you to the right regulator. Again, you see our phone number here, 888-466-2219. Our website, dmhc.ca.gov. We actually have an online form. I believe it's now translated in 18 languages and a paper form, but online you can submit a complaint either in English or Spanish. So just would encourage you, share this information with your friends and family. We want to make sure everybody is getting the health care that they need. On to return to office implementation. I know this is a very sensitive, emotionally charged issue, so I'm going to try to avoid the landmines. But maybe I will share a little bit of the things that keep me up at night and that I think about as the director. I will just tell you that I think I'm the parent of two young adults that actually missed graduation from high school because of the pandemic. I think they were loving doing school from home, from their bed in the dark in the beginning, and now do not want to ever do that again. I think what I've seen both in my immediate family with my staff is I think and again, just across the state and the country is the impacts of the isolation. We have seen significant increases in both depression, anxiety, social anxiety. It's been interesting to me to watch the evolution of, we saw a huge uptick in demand for virtual services, particularly if you think for therapy, some other behavioral services. And we're actually seeing an interesting trend of people wanting to have in-person appointments. I think there's a recognition that face-to-face social interaction can be good for us. So I don't have answers to some of this, but I will just tell you one of the things I have worried about with my team is the impact of telework and sitting alone in our homes, particularly those that maybe don't have family members at home or even pets. It's something that's weighed very heavily on me. As we moved to 2 days in the office last year, I will just say I think our Disability Advisor Committee was actually a tremendous resource. They actually came into our office, toured our facilities with our EEO office, with our leadership team, and made some really good recommendations for how we make our offices more accessible. We set up quiet spaces, recognizing that people may need to just take some time away. We made sure that we had appropriate lighting, that there was that we just set things up in a way that was helpful. And I will say, I think we came to the realization that the ADA requirements were the floor, but there were other things that we can do to really make our spaces accessible. I know there's been a lot of conversation about reasonable accommodation, and just to be clear, like we are looking at those on a case-by-case basis. But one of the things I think about a lot is how we've spent so much. We've done so much work to make our workplaces accessible, inclusive. The training we've done at the DMHC, I can't say enough about the work that our DAC has done to really educate our staff. I think Director Rutledge is going to be up next, but I think about Joe Xavier, the prior director of the Department of Rehabilitation, the work that's been done to make our workplaces accessible. I worry that all of our staff with with a disability have a reasonable accommodation, and we don't have them present in our offices. I think it's something collectively we need to think about, understand the importance of the reasonable accommodation process. And again, this is very, very case specific, but I worry about us not having that representation and losing the progress that we've made to make our workplaces accessible. So again, I know this is a sensitive subject. I'll just tell you, this is something that keeps me up at night, that I think a lot about, is just maintaining that progress and putting into practice all the work we've done to educate our team. So I'm happy to take questions and answer what I can. Again, I think we're on a path to bring people back and fill our offices July 1st, and just have appreciated the input from our DAC to help us do that in a very thoughtful way. Maybe just I'll show you our disability employment statistics here. So we've exceeded the statewide parity rate for employees with disabilities. The most recent data shows 25.37% of DMHC employees have been identified as having a disability, putting us at 52.68% of the parity rate. We have really, I will just say, I personally send out the emails when we send out the survey, when we announce Disability Awareness Month in October. I am also the one that will tell staff, I know the survey is confusing. Here's some tips and tricks for how to fill it out if you're a new employee versus someone who's filled it out before. So we've tried to do just an education about the importance of this. I think one of the things I've had I think this perception as well, I hear this from others, is there is a reluctance to identify as having a disability such as a skin condition or wearing glasses, or even a behavioral health, mental health condition, because you don't want to take away from someone with maybe a visible disability. And so we've done a lot to really educate on the importance of disabilities. There's a wide range, and it's okay to identify with that. It helps us to understand how we can make our workplace accessible. So that's our statistics. Again, I think collectively, for me in the last 5 years as the director, we have really tried to create a culture where all of our employees are seen, they're heard, they're able to feel safe to give input, they can show up as their authentic self. This really is at the core of our diversity, equity, inclusion, and belonging initiatives. I will say that I was adamant in adding the belonging because I think it goes beyond just having these embedded in the work that we do, but really creating a space for our staff to feel like they belong at the DMHC. And that requires a level of psychological safety, emotional safety. We've talked a lot about toxic culture within our department to address that. So again, I think part of this just goes back to creating a culture that is safe for everyone. Again, we've had our disability survey, which informs a lot of this work. We have attended career fairs really to make sure that we are trying to do recruitments for areas where we may be underserved, understaffed. I will just say too, we've required trainings on implicit bias and microaggressions. That is not optional. It's something that we're requiring. One of the things I get asked a lot is, what are some of the best practices for your disability advisory committee? And my biggest one is how critical it is for executive leadership to be engaged. That's from me on down. I meet annually with our disability advisory committee. I have my chief deputy and our admin deputy, who I think have presented here, attend their meetings on almost a regular basis. We have increased the visibility of our DAC within the department. I'll be very candid with you. I wasn't aware we even had a DAC when I came to the department. I know every department is supposed to be required to have one, but I didn't know what they do. We never heard much about them. And we have really changed that within the department. They do an update at our biannual all staff meetings. We used to have those quarterly. We have representation across all of our offices. They flagged for me that there were a couple offices that did not have representatives. And so we moved, I asked the deputies to ask, let's see if we can get someone, and we've been successful in doing that. They have frequent guest speakers from the disability community that we offer through lunch and learns to all of our staff. They present at every new employee orientation. So every employee that starts to work for the DMHC will know that they exist. And again, I can't underscore the importance of having leadership engagement in that. I probably talked about a little bit of this already. I will just say one of the other areas that we're really focused on, if you've heard about our Someone Like Me program, I cannot take credit for this. I have an amazing team that came up with this. And this is where we are matching prospective employees. So those that are applying for a job at the DMHC can request to be matched with someone like them, whether that's someone who speaks their language, of the same ethnicity, same religion, someone with a disability. We've had a number of requests for individuals who want to talk to someone who's also neurodivergent, and really to share what the culture is like. What is the culture going to be like for me with this disability, with this ethnicity? And it has been very successful. We have shared this program with a lot of other departments, but I'm very excited that our team has helped to come up with this, and DAC is an active participant. We have a mentorship program that we've set up to pair employees with a supervisor or manager. We're also creating an onboarding buddy program, which I am so excited about, where we'll pair new employees with someone in the department that maybe they don't normally work with, to ask kind of the silly questions of, like, there's no stupid question. Ask me, like, I don't know, where I go to find this, how do I sign up for the gym, or where do I put my lunch? Where's the bathroom? I don't know, whatever the questions are you have, or just, general questions about the work that we do and navigating, working with your supervisors. So excited about a lot of the programs that we're implementing there that I think are very supportive of creating an inclusive culture. And then last, I will just say I am so incredibly proud of our DAC who received the 2024 DAC of the Year award. I think that was either earlier this month or last month. You can see the pictures here. They are amazing. I will say, I think Mark Sumner may be on. I think Mark who's holding our plaque, has been on the DAC for 20 years through a lot of ups and downs. Just huge kudos. The leadership, this is not just a meeting for the sake of meeting. They actually have done a tremendous amount of work to educate our team, put forward recommendations, and really be a resource, I think, for me and for our leadership team as well. So that's a lot of talking. I will pause, and I'm happy to take questions on anything I gave an update on or anything else you want to ask me. I'll try to stop sharing here. Okay, there we go.
That was fantastic presentation. I'm going to dive right into some of the comments posted. And as you can imagine, and you mentioned this, that return to office is a emotionally charged subject for many, but you gave a very good perspective about isolation, depression, all of that is counterintuitive to, remote work, if you will. But at the same token, the comments, I'm just going to read it. Not all workplaces are accessible, and not all employees with disabilities can thrive in office environment. Telework works for employees with disabilities. And another comment was, I do not mean any offense, but I love interacting virtually because I feel that sighted folks do not see my blindness as visibly, as I receive less awkward questions and that may realize that I'm blind, but this is not so front and center. So social interactions are more seamless. Mm-hmm. That's just perspective of some folks with disabilities talking about, yes, the isolation, depression, so forth are true. At the same token, there's another perspective that we also want to present for a person with disabilities. Do you have any comment to address this?
Yeah, no, I do. And I hope you heard me in the beginning. I said, I don't have the answers to all of this. I think this is something as leaders that we have to grapple with. We did a tremendous amount of work during the beginning of COVID. And I'll be candid, I've shared this with my team. I've been a long supporter of telework. I benefited from it when my children were young. And I think we want to make sure we have a seamless and supportive environment, whether you are teleworking or in the office. We spent a lot of time really talking about how do we educate and support our managers and our staff so that when you have that mix, right, you have that hybrid, you've got some people on the screen, you've got some people in the office, or everybody on the screen. How do you make sure that we don't lose track of folks? That someone is never talking. Are we checking with them? Are we giving them the opportunity to voice their opinions? This is the being seen, right? And so I will fully recognize that for some of the people probably that made these comments, you're absolutely right. It's probably a better environment for you. That's the reasonable accommodation process that we're going through to review that. But how do we make sure that you're not lost in that engagement so that when whoever's coming back is sitting in a conference room and you're on the screen, how do we make sure we don't lose that engagement and that you still feel like a valued member of the team? So again, this is complicated. I don't have all the answers. I think it's the importance of the DAC in our departments, right? These are the people that can help us to think through these issues. So yeah, I appreciate the comments. I don't mind if you're more than welcome to disagree or criticize. I think that's the value. That's how we get better.
Carrie has her hand up. Carrie, go ahead and unmute and ask your question.
Thank you so much. Excellent presentation. I love the telework debate, and I actually have two questions, if that's okay with you. The first one is, if employees are having an issue getting their provider to provide a note for reasonable accommodation, would that be a grievance that they would file with you?
That is a tough one. I'll be honest. I mean, we recognize. I've read it. I've heard about it that there's a certain plan that is not doing that. I don't know that necessarily is going to come under under like something that we can handle at our help center. I will just say this, you're welcome to call our help center or submit a complaint. We usually will just engage with the health plan and see. I don't know. So our job is to enforce the law. I don't know that there's necessarily anything in like our body of law that says a health plan has to provide that. But you're welcome to contact our help center. I'll flag it for them that it came up and we can certainly see what we can do.
Yeah, I'm just trying to figure out how to organize around this issue because it
I
seems to be an
know.
issue and nobody seems to have the authority to deal with it. So I'm like, okay, well, who does
Yeah.
then? But I appreciate that.
I'm tracking. I'll just say I'm
Okay.
tracking. It's something we're looking into. It's a weird, it feels like an employment issue, but also a healthcare issue. So just I'll take that back. We'll continue to work on it, but you're
Okay.
welcome to come to our help center.
Mhm.
I will put in chat my email. If you have questions about the Someone Like Me program, you can email me. I'll connect you with the right person. And again, I would just say dmhc.ca.gov is our website. From there, you can find links to our help center, to the phone number
Mhm.
where you can contact us and submit a complaint.
Okay, thank you.
I'm going to go read a couple of more questions. Then it's going to go to Alex. He's got his hands up. One thing I want to add a little perspective. This thing that she just mentioned, Carrie talked about. We have heard this complaint quite frequently, especially in a wake of return to office mandate. Particular, I'm going to mention name here. Kaiser is one of the organizations that
Monday was
widely
that
told
regular.
providers that we're not going to provide a reasonable accommodation support letter. Like, that's their policy. I don't know whether that's true or not. I haven't heard from Kaiser, but that's the complaint I got. But one of the other question that was posted here, which unit is responsible for your Someone Like Me program? And can you give some additional info on that?
Yeah, so I'll just, again, I'll put my email in the chat. You can email me and I'll connect you. It is, I believe, being coordinated. It's through our Office of Administrative Services, but I think it's coordinated both through our HR department as well as our DEIB unit. So happy to share information about that. They would love to talk to you about it. But it's something that we put on our recruitments and people can request, and we're happy to connect them. I will just say I've heard about the Kaiser issue. I think this varies from provider to provider too. So and again, one of the other things that you can always follow up with, like call Kaiser's member services or file a grievance and see if you get any traction there. I'll flag it though for our help center, and if there's any other information I can share, I'll certainly follow up, Bobby, with you, and you can push out information.
Great. Absolutely. Thank you so much. The other question is, would very much appreciate, Valerie's asking, very much appreciate knowing the specific training the managers receive on disability related matters and so forth. And Valerie, feel free to unmute and clarify your question.
Maybe I'll just say I don't know specifically what training we have done for super. Happy to follow up on that. I know we've done training. Hang on here. We specifically have done training on just kind of the for engaging with those that are neurodivergent, for just how in the kind of the interview and hiring process you can make sure we're making our workplaces accessible. I'm trying to think what else. I mean, again, we have in our all staff meetings, our DAC is doing updates. We're doing lunch and learns. Again, I'll put my email in. If you have specific questions about the training, I'm happy to connect you with the person that does our training too.
Right. Alex, go ahead, unmute, ask your question.
Right. Thanks, Bobby. Thanks,
My
Mary.
apologies. My apologies, Alex. Maybe after Alex, Bobby, I also have a
Yeah, right.
question.
Oh, Glenn. Hello,
Thank you,
Glenn.
Glenn.
No worries, no worries. Okay. 3 questions, and I just want to make sure I understand this clearly. So does DMHC take complaints of state employees for medical coverage provided from state employment insurance coverage? I think the answer is yes, but I want to be sure.
Yeah, so there are a couple CalPERS products that I believe have like CalPERS in the name that are self-administered by CalPERS. the majority of the remaining coverage that state employees get through CalPERS is under the DMHC's jurisdiction. So, for example, if you have Kaiser, if you have United, Anthem Blue Cross, Blue Shield, those are likely under the DMHC's jurisdiction. So for the majority of state employees, if you have a problem with the healthcare coverage you're getting, you can come to the DMHC. And again, if you don't worry about if you are or you aren't, just come to us. And if you're not, we'll get you connected, whether it's back to CalPERS or if it's, you have it's coverage through a family member, we can also get you connected with the right regulator if we need to. Just for some context, what we usually will do is if you say, I have a complaint about, let's just say it's Blue Cross. We reach out to Blue Cross, ask them for more information. They will usually very quickly tell us either this is under the DMHC or it's in somewhere else. I won't get into details with all the other places it could be, and then we'll connect you with the right regulator.
Okay, thank you. And then two other questions. Does DMHC have metrics applicable to tracking numbers of persons with disabilities that are impacted by DMHC's umbrella? And then also related to that, does DMHC have metrics tracking how many are employed and unemployed and the duration of that status that are under that umbrella as well?
Did you say employed or unemployed?
Yeah.
Yeah, no. So unlike, I'll just say DHCS or Covered California that are actually administering programs, we are the regulator. So we actually get very little information about the people that are enrolled with the plans that we regulate. We're starting, actually this year, we're collecting information as part of our Health Equity and Quality Initiative that will give us some more insight into the services that are accessed, but we don't collect information on employment, status. I'm not sure if we collect disability status. What we would have information on is whether someone has requested a service that may be related to a disability. So we do have some information there. We have, if you're interested in information on those that have submitted an independent medical review request, we do have information on our website that can give you some sense of like the outcomes if someone requested a service. So we have some information we'd have to kind of dig into, but I don't know that disability status is necessarily a category that we collect. And again, we're not getting like information about each of the 30 million people that are under our jurisdiction.
Okay, understood. Thank you. I was just curious about all those aspects and how they intertwined into your department. So appreciate it. Thank you.
Glenn, you're next. Go ahead, ask your question.
Thank you so much, Bobby. And thank you likewise, Mary, for a very wonderful presentation. I must say that I'm really impressed by the disability and neurodivergent efforts of the department. I also have I have the wonderful opportunity to work with folks from DMHC for the past decade, doing medical audits. So I really appreciate it. But my couple of questions is towards the health plans and health providers. And in a way, I also would like to circle back to what Bobby was saying about the challenges in basically asking provider to help out with reasonable accommodation documentation.
Yeah.
As a result of that, I also personally had difficulty navigating that. And one thing I've been trying to see is try to find out, what I would call the neurodivergent or disability affirming providers. That is very difficult to find them. And not only that, there is also a couple of things that I'm also having difficulty finding in terms of provider directory information and things like that, as I have also have a couple of kids who are neurodivergents with disability. And that is also psychiatrists that cater to both ADHD and autism spectrum disorder. So my question is, would we see any efforts in terms of health education, cultural and linguistics, or even provider directory requirements in the future, where it's going to be easier for consumers to find or to reach out these neurodivergent or disability affirming providers, and also psychiatrists who cater to both ADHD and autism spectrum? Thank you.
Yeah, no, good question. And I'll say, I mean, I think this is, we actually have a neurodivergent affinity group in our office, and this is something I think that we're all, I will just say, I feel like this is a fairly new condition that we're talking about. And someone on here can tell me if I'm wrong, but I don't believe it's in the DSM-5, the latest version of the DSM. So I think that may be layered on some of the challenges. What I would say is if you are having an issue finding an appropriate provider, contact your health plan. If your health plan's not able to help you get connected to an appropriate provider, please call our help center. I think that's something we often do, what we call a warm transfer, a three-way call with the health plan to really understand and try to find an appropriate provider. There are timely access standards in the law, which essentially, for the most part, you should be able to get an appointment within about 2 weeks. And so if you're having issues getting connected with the appropriate provider, if you're not getting help with your health plan, I would contact our help center, and we can certainly try. And again, I think I'm excited to see kind of how we collectively talk more about those that are identified as neurodivergent, because I do think this is still fairly new, and I don't even know within the provider community whether that's something that we necessarily have identified the right providers. I don't believe there's a requirement for them to identify that in the provider directories. We have a lot of laws around provider directories, but it's really kind of identifying their specialty, and this would be probably more of a subspecialty. But again, contact our help center if you need help finding a provider.
Thank you so much, Mary. Yes, I did contact also our health plan. My wife is a wonderful plan at the University of California. They even have their health plan. Their health plan there even have this customer service called Accolade, which provides, which is like a patient advocate service. But even there, I was still having so difficulties finding this neurodivergent provider. Affirming providers couldn't even get to one. Had the services and all the expenses, encounter and all that. It was still not, I still didn't get the help, and I'm trying to engage with them more because, like you said, this is really something new.
I think it is. And again, I hope that we continue to evolve and it becomes something and again, I think some of this is just getting it into kind of the clinical standards and the appropriate diagnosis categories, which I think we're not quite there yet. But again, I would encourage you to contact our help center, and we can certainly talk to the plan and see if we can help you find the right provider.
Thanks, Glenn, for that excellent question. And thank you, Director Watanabe, for a comprehensive response. Since we're talking about network and providers, I want to take the opportunity to ask you another question, which is a systemic issue for many of the smaller managed care plans list providers that only exist in a fictional world, but in real world, people have problem locating them. And the problem's gotten so worse that they're calling, there's a term for that, ghost network. Where,
very familiar.
Right. So, and legislatures trying to address it. There's been, various laws and so on. Is there a particular strategy or plan that's been implemented by your department to address this problem?
Yeah, I'll tell you, I came to the department 10 years ago, and one of the first things I was assigned to work on was a newly signed legislation called SB 137 that mandated certain requirements on provider directories. It requires providers to update their information at least once a year or twice a year in most cases. There's federal requirements that have quarterly updates, and there were requirements about the information that had to be in the directories. It really took consumers out of the middle. So if they relied on a provider directory, they, wouldn't be charged if they, the provider ended up not being in network. We have spent a tremendous amount of time on provider directories. I could talk for hours about this, but probably about 7 or 8 years ago, there was a merger with Blue Shield and one of the Medi-Cal managed care plans that resulted in us requiring Blue Shield to invest $50 million in trying to come up with an industry solution related to provider directories that ultimately evolved or resulted in the Integrated Healthcare Association creating what we call Symphony, or a centralized database. idea here is that plans would put in their provider directory information, providers, so doctors would update their information in one central place, so that you don't have some doctors contract with 15, 20 different plans. And so they have to update their information regularly with everyone. Every time something changes, they have to update it. So I think one of the things that I have been surprised to learn is just the volatility of that data. The provider information beyond just their name and the language and their specialty, but their practice location, whether they're accepting new patients, their affiliation with health plans changes quite a bit. Plans and providers are not required to use Symphony, so this has been voluntary. Part of this 50 million was really to encourage industry-wide participation. We're not there yet. We've made some improvements, but I think what I would say at the end of the day is there is a lot of work happening to improve provider directories. We're not completely there. As you mentioned, there's a lot that has to do with these ghost networks. You see a provider in there, you call and they say, I don't take your insurance, or they're not practicing anymore. At the end of the day, there are a tremendous amount of consumer protections though. So one, if you rely on the information in the directory, you shouldn't be responsible for paying as if you went out of network. If you call and report the information is incorrect, the plan has a very short period of time, really, I think it's less than a week, to update the information. Again, I would encourage you, if you have problems finding a provider, you use the directory and there was a problem, you can come to the department. This is actually probably one of the easier calls we get, when someone will say, I've called 5 people in the provider directory and no one's taking new patients, or it's going to be 2 months. We get on the phone with the health plan, and it's really the plan's responsibility to arrange for care. We've had a number of bills signed in the last few years that is putting the responsibility on the health plan to arrange for healthcare, particularly in the behavioral health space. But if they can't provide an appointment within the timely access standards in the law, or if it's geographically accessible, we have standards for that. They need to do the homework to find you a provider. So again, I know it's a hot topic, ghost networks, but there's a lot of work that we're continuing to do to improve provider directory accuracy. But at the end of the day, for real people just trying to get an appointment, call your plan, but also call our help center.
Thank you so much. And I want to commend you on getting such a high disability parity employment within your department. 25% of your DAC's been recognized. And one thing I want everyone to recognize, what you said at the beginning of this, is culture change. It's not just the survey. It's like making people feel comfortable, where you can come out and say, I need this, I need that, and I'm a person with disabilities. So the culture change is really the key to success of many of the high-performing departments in this particular arena. So I want to particularly acknowledge the great work that you have done and the leadership that you provided to achieve this fantastic accomplishment. So keep up the good work. Are there any other questions for Director Watanabe? Before I say goodbye to her, I want to make sure that all of you have adequate opportunity to utilize this fantastic resource. And we have Carrie. Carrie, go ahead, unmute, ask your question.
Sorry, one last really quick question. Do you regulate third-party administrators as well? And if not, who does?
No.
Okay.
I'll be honest, it may be a gap. Depending on what they do, there may be some regulation, but for the most part, we don't. I will just say this. If there is a third-party administrator, for example, that is contracting with a health plan, so if there's a health plan that's regulated by us and they are delegating functions to another entity, we ultimately hold the health plan accountable, but there are third-party administrators that do other work. There are some that work with self-funded plans that are regulated by the Federal Department of Labor, that are not under our jurisdiction. There may be some federal oversight, but I'm generally not us.
Thank you.
Thank you. Was that Carrie, right? Do we have any other questions? Michelle, you raised your hand. Please go ahead.
Hi, I have a question. So my question is, I also have Blue Shield and Medicare and Medicaid. What is my primary insurance? And I noticed lately that my prescriptions are getting a little too high. So what is my primary insurance? That is a
Yeah.
question.
Yeah, no, it's a good question. And I think it can depend on what service you're getting because there are some things that are covered by Medi-Cal or Medicare. I will just say if you need help with any of that, you can call our help center. They can help you navigate that. I think some of it will depend on what the issue might be. And again, Blue Shield may be able to help you with that as well. On prescription drug costs, this is the cost of healthcare is something that weighs heavily on me. In addition to worried about my employees, we are seeing a lot of the rising costs of healthcare attributed to pharmacy drugs, prescription drug costs. We actually have a proposal that was in the governor's May revise for us to license and regulate pharmacy benefit managers to bring more transparency to their role in the healthcare delivery system and in the cost of prescription drugs. I think, I don't know if you've had presentations from the Department of Healthcare Access and Information. There's a lot of work that they are doing as well within the state to try to manufacture some of our own prescription drugs, try to lower the cost. So I recognize it is a huge issue, just the cost of healthcare more broadly. You all are seeing it every year at open enrollment, but prescription drug costs are a big issue. So don't have any answers for you other than we're trying to bring more transparency and oversight to that process.
Thank you.
You're welcome.
Thank you. And looks like we don't have any other questions. I'm sure there's a lot of people want to ask you a ton of questions, keep you here all day. I personally want to follow up on a bunch, but I'm not going to take up your valuable time. We really enjoyed your participation. It's been a fantastic source of information. So thank you. And we also got a lot of requests for sharing your slides. And
okay.
Is it okay to share that with the group that you?
Yes.
Great.
Yes. No, absolutely. And I know Nicole Eshelman, our admin deputy, I believe has been responding to some things in chat. So she would be a fantastic contact for someone like me if you want to know our supervisor training. If Nicole hasn't put her email in, I'm sure we can get that. I will also put mine in. You're welcome to follow up with me. I'll make connections within the department. And again, if I have anything more on Kaiser or others and the reasonable accommodation process, I will share that, Bobby, with you, but you're welcome to share my slides.
Great. Thank you so
for the
much.
opportunity. Yeah.
And I also know Nicole, she's actually presented here before, very informative as well. So thank you, Nicole, for providing your contact information on the chat. And Director Watanabe, thanks again. You're welcome to stay on. If not, thanks again for taking the time to present here at this important platform.
Yeah, happy to. Thank you.
Thanks.